Welcome everyone. My name is Lloyd and I'll be your moderator during this session. I'll be monitoring the Q&A and the chat box, so feel free to ask any questions during or after this presentation. This is a live presentation, and after the presentation, Roy will be answer the questions posted in the Q&A for you. Over to you, Roy.
Thank you so much, Lloyd. Hi, everyone. I'm very excited to be here today. This is a live presentation, so all mistakes and gaffes are authentic. Here we go. I'm going to get started. So I'm at the Israeli Ministry of Health, the Director of Research and De-Identification at the ministry. I'm also one of the FHIR leaders at the ministry. I'm going to tell you what that means in a minute. Here in Israel, we have a unique ecosystem, as I imagine every country does. We have 4 HMOs who are insurer providers. So they have to cover all the residents in this country. So they have to provide insurance to whichever resident applies to them. And all residents have to be insured by the HMOs. So all of the population here is covered, whether or not you are a citizen. And the government pays the HMOs basic insurance through Social Security, and there's a capitation for that for agent and whether you live in the periphery, but also it means that HMOs can also have expanded packages in this country. These are the 4 HMOs that we have: Clalit, Maccabi, Meuchedet, and Leumi, and that's their share of the market. So the HMOs are the payers, the hospitals are the payees often. We have 30 general hospitals as opposed to psychiatric or geriatric. 11 that are government owned, evolved sometimes to military owned. 8 that are Clalit owned, the big HMO. And so Clalit and the government basically split the share of the market. Clalit also has more than 50% of the insurees in the country. And then the rest are between the other HMOs and private owned. And of course, we can't talk about the healthcare ecosystem without talking about the innovators, the startups. So we have more than 500 startups that specialize in healthcare innovation. They already collaborate with HMOs and hospitals on research and product innovation. There are also organizations who took on organizing innovation networks. So 8400 really focuses on the leaders that are already existing in the healthcare ecosystem, and FHIR is one that focuses on creating kind of more grassroots in different kind of ranks, mid-level, high-level, so collaborations. And there are others, of course, and Google has one, different companies have one as well. And the Israeli ecosystem has a mass interest in foreign markets. We're big on innovation, but our startups also love looking at, especially the US, but definitely Europe. So we're very outward facing as well. So I want to tell you a little bit about how we looked at FHIR adoption. So we're started out as a team of 4, and we started out by really having one-on-one meetings, face-to-face, with different people in the healthcare organizations in the country. And we found that initially there was only really one HMO that worked on some sort of partial FHIR adoption, and they did it for internal reasons. And if we ask ourselves why in 2019 that was the case, we found that maybe, we tried to reflect, and I think maybe initially there was unclear messaging on standards from the government. So the Ministry of Health has started the conversation on FHIR and kind of gave it up. And then there was FHIR versus OMOP, and there was just like a lot of, it wasn't clear where government was pushing when it came to standards. There was difficulty telling apart FHIR from other HL7 standards, V2, for example. That kept coming up in conversations, like how would we, a hospital, know that FHIR is worth, all this investment? How do we know that its destiny is not going to be what happened to HL7 V2? That was all the rage. So that's something that you always have to deal with. There was an incentive problem. If you talk to HMOs about why should they, adopt FHIR? One of the reasons would be, well, if you're payee moves to another network and you want to do some sort of study, you want to have you want to have a data standard that allows you to do it. But in Israel, very few people transition between HMOs during their lifetime. So that's a big reason for HMOs to not care about standards, because basically for them, their standard is the standard for when it comes to data or profile or model. And there's a people in the room problem. When you have a meeting about data standard, when you have a meeting about FHIR, you need to have an IT person in the room, you need to have an innovation, a business strategy person in the room, you have management. It's a lot of people. It's a very broad conversation, and it's hard to do. So our process was, our team of 4, we talked to everyone who would take a meeting with us, really. We talked to equivalent teams around the world. We had face-to-face meetings with healthcare organizations in this country, startups, EHR vendors, big tech. We tried to understand why people would want to adopt FHIR. We tried to listen to what incentives they would be looking for, what use cases might be relevant for them. And we tried to understand if there's any expertise in the market. We found one really good person, and that's how we became a team of 5, because we recruited him to work part-time for us. Our first challenges as we were kind of starting, and remember, all this started just more than a year ago. So, firstly, comparables are tricky. Israel started out by having quite an advanced clinical file EHR digitization project, sorry. So there was not that much of an incentive as it were in the US, where they had to go from paper to digital. So that was something that we had to deal with. We're already digital, but we don't have FHIR. And also it is tricky in Israel to talk about legislation when it comes to healthcare and healthcare data. And this is something that we're not yet looking at even. So that's another tricky thing for us when it comes to especially the US. But what we did learn from the UK was that a dedicated team when it comes to FHIR is the best catalyst. So we realized we had more than enough to really get started. And what we did was to try to really create buzz. I mean, we couldn't really start by having a real FHIR adoption, like technical project going, but we wanted people to know that this was where the ministry was trying to take the industry. So of course, some of the challenges were smaller healthcare organizations want the big healthcare organizations to start, and big healthcare organizations want government to show them that they're serious, which usually means money. But government, when it needs to put money down, needs to show that it's organic, that's something that the market actually wants, and it's not going to be a failure. So there's this chicken and egg problem, as we say. So we, in order to solve all of these challenges, as I said earlier, we looked externally at different markets, but we also looked at external consultants. We're a government, so we can spend money on advisors and consultants, and we did that. We found some great consultants internationally. We asked them how to approach national adoption, what are some realistic timelines, what to talk to, how to present this to healthcare organizations, how to listen, what kind of talent would they need, how much funding would it take, all of that, learning from people who have consulted and have applied FHIR in different other markets. We expanded our core team. We realized we needed a technical project manager, and we brought her in internally. We developed a strategic partnership with 8400, which I mentioned earlier. It's a nonprofit that focuses on healthcare leaders in this country, and we really needed it because government has a very mixed reputation often, government projects, and we really needed that grassroots legitimacy. We needed their flexibility in hiring and spending money, which we often don't have. So that was a really good buy-in for us from 8400. We also started a technical FHIR team. So we hire an architect. We're now hiring a project manager and a data engineer, and they're completely outsourced to help healthcare organizations and startups learn how to use FHIR and publish on Simplify and stuff like that, write FHIR documentation. So that's a resource that we as a government can and are offering already. We are hiring international advisors, including FHIR, of course, to give our healthcare organizations, our leaders, our technical people in as in the ministry, but in hospitals and HMOs. They offer workshops. They could be very technical or they could be very strategic. And they will offer one-on-one consulting to different organizations. There's also our RFP that we already started publishing, which will allocate around $70,000 to each FHIR adoption project around the country. And that's what we're surmising it'll be enough for a part-time 2-person team to accomplish a FHIR project. And our goals with this RFP is really to encourage healthcare organizations to bring their own pain points so we can learn about those, and also to let them see the value in FHIR adoption immediately, as opposed to something that's very long-term or strategic, because then it would probably just die out. Of course, we're government, so we're always like full of self-doubt and self-deprecation. So we always think we don't know if it's enough, but we'll see. We'll see how this RFP goes. And I think what we are seeing is that people see that our investment should be taken seriously, and it is. And we're talking to different other ministries about how we could cultivate this investment in FHIR nationwide. Yeah, we're also appointing a FHIR steering committee to develop the Israeli standard. So, one thing that's unique about Israeli healthcare data is the primary key is national ID. So you can find any person in any healthcare data point, because you have to use the national ID in order to get treatment, healthcare in this country. Even residents get it. Not always, but often. So there's a lot of things that are unique about Israeli healthcare data, and there's a steering committee in place that will decide on how to apply that in the FHIR standard here. We're also investing in community building, in digital platforms, presence on all these different platforms, building our own website, starting a digital Israeli FHIR community on Confluence. And investing in workshops, and continuing to invest our time in meetings with different FHIR leaders locally and internationally. We already found an amazing woman who might be one of the leading figures here, who already is interested in being a community leader, and has a very interesting background. We would have never found her had we not taken to like LinkedIn and all these spaces to look for emerging leaders in this field. Yeah, when it comes to government, people often want to hear about regulation. There's none. We're not thinking of any right now. There are challenges when it comes to regulation. It's hard to figure out whom to regulate. Are we regulating the HMOs, the hospitals? Are we regulating the leading EHR vendors? I don't know if I really pushed a point earlier, but there's one big EHR vendor for hospitals, one big EHR vendor for HMOs, and then there are a lot of smaller ones. So whom do you talk to? Whom do you regulate? How do you make sure that business continues, all the regular regulation problems? You don't want to prevent business from being done, but you also want to direct it in the direction you want. And there's still a lot of open-ended questions. So we're still learning as government, and until we feel like we know enough, we're not gonna take this down the regulatory path. But we definitely are looking at it from the point of view of investing in positive encouragement, as opposed to regulating into a path that we're not yet. We don't know how to do that effectively. So because a lot of you are not Israeli, I just wanted to kind of give you an idea of what the opportunities could be in this ecosystem. Israel is amazing. It has a lot of dynamic people, great English often, and a lot of people want to work with external players. In the FHIR ecosystem, we're looking for people who are FHIR savvy and interested in collaborations. Specifically, my team could always use to work with FHIR technical people. These are our contact information. This is our contact information. My name is Roy Cohen. My colleague is Yoel at the ministry, and feel free to email us.
Okay, thank you, Roy. Let's proceed now to the Q&A. Okay, our first question, do citizens get to choose which of the 4 HMOs they can be part of, or is it decided some other way?
Yeah, you can choose, you can transfer once a quarter, I think, in Israel. You just have to apply through the Social Security in this country. But there was legislation in 1994 that made it possible for citizens to transfer between HMOs and made it impossible for HMOs to say no. So.
Okay, another question. Are there serious data privacy concerns on healthcare data in Israel, like in Germany, where data privacy sometimes overrules any smart idea of making use of data, or even prevents data from being sent to another party?
Yes, there's privacy regulation in healthcare data. I'm not much of a regulator, but my field of regulation is privacy in questions when it comes to research. There is bureaucracy that is in place in order to protect people's privacy. However, the bureaucracy wants to learn and is constantly changing, and we're constantly in the process of rewriting regulation from the 60s and 70s, rewriting legislation into new regulation, in the sense that we are aware that privacy questions can be a block to innovation. At the same time, you need to think about how people's rights have to be protected, especially if they never signed up to have their data be looked at or studied by an entrepreneur or an innovation leader at a healthcare organization. So there's definitely always a tension between privacy and innovation, and there always will be when it comes to healthcare data. And it's a healthy tension because people have rights and we have to protect them. But especially the people I work with have a good literacy when it comes to that and make smart decisions, I'd like to think.
Okay. Next question. Do you have an example of the immediate benefit of FHIR adoption?
Mm-hmm. Yeah, I mean, that's a great question. I think when it comes to the Israeli ecosystem, a lot of people are looking at prescriptions and how, if a hospital prescribes like a medication, it has to arrive at the HMO, because the HMO is really the one that helps, that ensures the patient, and is the ones that's supposed to like cover that medication. But it also should go out to all the large pharmacies because they're usually the ones who sell the medication. So that's a big problem. That's a big data or data standard problem that could be solved. That could be, I don't know if it's immediate, but it's a big problem that FHIR can help us solve. I think that's one of our challenges, is really to understand, all right, what's a big problem that's really big for people, and what's a low-hanging fruit problem that's immediate but is still important enough. If it comes to an EHR vendor, for example, if they could build healthcare, like a clinical file, EHR file for like an allergy specialist, we know that that's something that allergy, there's a big need in the Israeli market. And if it could work with FHIR, then we could open a new market here when it comes to allergy specialists. So there's a lot of need for innovation, and that FHIR could accommodate for. And we're still in that stage where we're trying to understand what's immediate and what's big.
Okay. We have another question. Have you ever adopted or at least proposed a FHIR-based app in response to the COVID-19 in Israel?
No, we're not there yet.
Okay. Now, for strategy, what was your best example of value added for FHIR in dealing with some global South-based ministries of health?
Yeah, I mean, integration. So a lot of times we need to, when we talk about strategy and FHIR, we are pitching integration. So how do you integrate between different data systems? That could be internally in a healthcare organization. They have a lot of different systems, or between a startup and a healthcare organization. So I'd say when it comes to strategy, we always talk about integration of systems.
Okay. Yeah, I see there's, yeah, we seem to be running out of time. Maybe
Yes.
you might be able
Sorry.
to answer one last question. In dealing with some global South-based ministries of health, we run along similar problems with investment in interoperability, given there's is mostly one nationally supported EMR system. Similar to your problem with everyone mostly staying with one HMO throughout lifetime.
Is that a question?
Yeah, that seems to be a question, but I don't fully understand it. But yeah, anyway, yeah, you can answer that later on today. We've run out of time. So yeah, I'd like to thank you, Roy, for taking your time to present your presentation. We hope that the delegates found this session useful. Please do not forget to rate the presentation and use the Q&A function if you still have remaining questions. Thanks for attending and have a nice day. Goodbye, Roy. Thank you.
Thank you so much. Thanks, everyone.
Bye.